Hello and welcome. I'm Elisa Hernandez, a librarian at Stanford Health Library. Thank you for joining us for our talk, Breathing Easy, Understanding and Managing Asthma in Adults. It's my pleasure to introduce our speaker, Lauren Eggert. Dr. Eggert is a board-certified, fellowship-trained pulmonologist and a clinical assistant professor in the Division of Pulmonary, Allergy, and Critical Care Medicine at Stanford University School of Medicine. She is an expert in the diagnosis and management of diseases of the airway, with a focus on patients with allergic asthma. She also treats chronic obstructive pulmonary disease, allergic bronchopulmonary aspergillosis, and chronic cough. Dr. Eggert also practices critical care at Stanford Healthcare Valley Care. Throughout the talk, please enter any questions in the Q&A box at the bottom of your screen, and at the end of the talk, Dr. Eggert will answer as many of those as possible. Over to you, Dr. Eggert.
Thank you so much. And thank you all for having me. I'm really excited to talk to you tonight. Just give me 1 second while I pull up my screen. All right. So again, I'm Lauren Eggert. I practice mostly at Stanford Healthcare, where I see patients with disease of the airways, including asthma, COPD, and chronic cough. And I'm very excited to be here tonight to talk to you about understanding and managing asthma in adults. I've got a lot of material to cover. I'll try to get through it as best I can, and at the end, make sure I save some time for questions. So what are we going to talk about today? So I'd like to start by talking about what is asthma, the definition and prevalence, risk factors for asthma, different types of asthma, mostly allergic, non-allergic, but there's some other types of asthma as well, how we diagnose asthma and evaluate for allergies and other related conditions, assessing asthma severity and control, general principles of management, managing triggers and the asthma action plan, and just finish up with a few key points about maintaining the health of your lungs. So really important, what is asthma? I've highlighted some key terms here. Asthma is I think it's important to note it's a very heterogeneous disease. It's not one size fits all, but at its core, asthma is defined as a disease of chronic airway inflammation. There's classic clinical symptoms and things in the history that include respiratory symptoms such as wheezing, shortness of breath, chest tightness, and cough. And importantly, they tend to vary over time and intensity and are often in response to triggers. But more so than just clinical symptoms, you need to have evidence of reversible airflow limitation. And the most common way we do this is with breathing tests called pulmonary function testing. So a little bit, here's a pictorial of kind of the airways and what they look like in a normal person and in someone with asthma. So here on the left, you have your bronchus, one of the airways, which on the outside you have cartilage, and then you have your mucus glands, and on the inner layers you have this smooth muscle layer. And in response to triggers such as pollen, cold air, exercise, what happens is that smooth muscle layer constricts, making it difficult for air to get out. And over time, that smooth muscle layer can thicken, so making it even harder to get air out. You also get excess mucus production from those mucus glands, so you can have a lot of mucus and phlegm. And all of this combined, the tightening of the muscle, the increasing in the size of the smooth muscle, and all the mucus makes it very difficult to get air out. And you can see here on the right, I just have some fancy pictures on the top that show the mucus blocking up the airways, and what you would see under the microscope, where all the inflammatory cells get in there and lead to all these problems. So how common is asthma? Asthma is extremely common. Prevalence varies by area, different states, countries, but in general, it's about 1 to 18% of the population, depending on the country. It affects about 235 million people worldwide. In the US, the prevalence is generally estimated at about 8%, in some areas, maybe as high as 12%. It's thought that probably at least 1 in 13 people have asthma in the US. There does tend to be a higher prevalence among African Americans and lower income households. Interestingly, in childhood, asthma is more common in males, but as you get older, around age 20, it kind of evens out with a similar prevalence among females and males. And then after age 40, for probably multiple reasons, it does become more common in females. And, there is mortality, people do die of asthma. It's low, but about 12.6 people per million do die of asthma in the US each year. So what are risk factors for asthma? So like many diseases, it's probably a combination of both genetics and exposures. So in terms of genetics, it's more common to have asthma if one of your parents have asthma, or if you have a family history of asthma, but it's not a simple inheritance pattern. It's not like if mom or dad has asthma, that you have a 50% chance or a 1 in 4 chance of having asthma. But there is some genetic contribution that we're just beginning to better understand. And then you have to add this genetic predisposition and combine it with your different exposures. So there's 3 main types of exposures. The first one is perinatal, or even before you're born. We know that if your mother has poorly controlled asthma during pregnancy, that increases the risk for the child having asthma. And things like maternal smoking during pregnancy also increases the risk of childhood asthma. In addition, there's important contributions from occupational exposures. Probably about 10% of asthma is due to workplace-related exposures, and this represents a specific type of asthma called occupational asthma. And the most common occupations associated with occupational onset asthma tend to be things like nursing or cleaning, where you have a lot of different exposures. Lastly, there are other environmental exposures, including early life exposure to air pollution and definitely smoking. Exposure to smoke or a personal history of smoking increases your risk of asthma. Interestingly, there are studies that show that children who grow up close to major roadways have a higher risk of asthma from pollution. That's something, that we know from studies. So there's definitely a big contribution from environmental exposures. And then I just want to get a little bit more, this is kind of into the heterogeneity that I mentioned of asthma, how it's not just a one type fits all disease. And this is just a slide outlining the different types of asthma that we see, depending on when in life it starts. Asthma tends to be a disease of childhood, but it also happens again in adults. And I see patients, in their 70s or 80s all the time who have new onset asthma, and they're so confused. They're like, but I never had childhood asthma. I never had any problems till now, but it's something we see. And you can see these are some fancy words that are very hot in the asthma world. We call Th2 and non-Th2. So Th2 is your more allergic, inflammatory asthma, and non-Th2 tends to be your non-allergic asthma. So for your allergic type asthma, that's more common with childhood asthma, exercise-induced asthma, which is this EIA, AERD, which is a fancy kind of asthma where you also have an allergy to aspirin or ibuprofen, and nasal polyps. And then your non-allergic type asthmas, we often see very late onset, as I was mentioning, often in women. There's a whole category of asthma that's associated with obesity or being overweight. There's smoking associated asthma, which tends to have a very different presentation than non-smoking associated asthma. And these are many of the things that we see in terms of the disease. And again, just another very complicated slide, just showing you all the different chemicals in the body that are involved in these pathways. On the left here, the type 2 or that allergic pathway, and on the right, the non-type 2 or the non-allergic pathway. And these are some of the chemicals that are targeted by many of the new injectable drugs that have been developed to treat asthma, which is why these are important. But at the end of the day, they're all going to lead to the same thing, those changes in the airway, that smooth muscle growth, that clamping down of the airway, that mucus, excess mucus production, all the things that make asthma, where you just have trouble getting air out. So, how do you diagnose asthma? So, I kind of mentioned in the beginning that asthma is a disease where you have characteristic clinical symptoms, but you have to back it up with objective findings. So, asthma diagnosis is two parts, those characteristic symptoms and clinical history, but you also want to confirm the presence of difficulty getting air out on lung function testing, or pulmonary function testing is another name for that. And you want to confirm that there's excess variability in your lung function. That's what makes asthma different than just COPD or chronic obstructive pulmonary disease, where your problem with getting air out is fixed and not reversible. In airway, it should be reversible. And important, the guidelines always say test before treating whenever possible. I can't tell you how many patients I see that get referred to me for asthma because they're short of breath or they may be wheezing, who have a totally different lung problem. And I can usually figure that out when I get lung function testing and see, that there's not obstruction or there's not variability. And I think that's helpful because then it lets you know that you need to keep looking and make a different diagnosis, and also that the treatment is not going to work if you try to treat it like asthma. So what are the classic asthma symptoms? Cough tends to be a predominant symptom. One thing, as was mentioned in the introduction, I also do a lot of chronic cough. And one of the findings that is quite specific for an asthma type cough is a cough that causes nighttime awakenings or early morning awakenings. Most other types of chronic cough will not wake you up at night. So that's an important finding. And when you're assessing someone's asthma control, I always ask about nighttime awakenings or early morning awakenings as a way to assess asthma control. Other things would be episodic chest tightness, wheezing, shortness of breath. And these respiratory symptoms tend to be worse in response to specific triggers. For many people, this is allergens, whether that be perennial allergens like dust mites, mold, or more seasonal allergies, pollen, trees, grasses, also cold air, strong smells, exercise tends to be a trigger for many people, viral infections. One of the classic things I see where people really first notice their asthma is that they have prolonged symptoms after a respiratory infection. So something I hear all the time is that my kid came home from daycare. I have 2 kids in daycare. I know how it goes. You're sick a lot. My kid came home from daycare. We all got a cold and everybody else got better in a week or 2. And I kept coughing or I was sick for weeks. And this is something we see very common, is that patients who have underlying asthma often, have prolonged recovery after respiratory infections. And then something that also helps us is that if you're given a rescue inhaler, like an albuterol inhaler, which opens up the airways, you should feel better. So if somebody tells me, my primary care doctor gave me a rescue inhaler when I wasn't feeling well and I use it and it makes me feel a lot better, that's also very suggestive of asthma. So whenever I'm meeting someone for the first time in clinic, I go through a lot of things. I take a very extensive history. All these things help me confirm the diagnosis and figure out how best to treat it. I ask everybody about their birth history. Again, I mentioned that perinatal, pre-birth exposures we think are very important and contributing to the development of asthma, but there's also many conditions that can look like asthma that are not asthma. So something I commonly see for people who are born prematurely and who need oxygen in the first weeks or months of their life, that there's something called bronchopulmonary dysplasia, where the lungs don't develop normally. That can also give you wheezing and difficulty getting air out, but is treated very differently than asthma. I'll ask about age at diagnosis. I'll want to get a sense of how well controlled people are. I ask, how many times have you gone to the ED? How many times have you been hospitalized for asthma? How many times have you been given steroids? Have you ever needed to go to the ICU? Have you ever been on life support? Trying to get a sense of the type of asthma people have. I ask them about their environmental allergies. their allergy symptoms, whether they tend to be worse in different seasons, whether there's certain things at the home that trigger their symptoms. I always ask about other medical problems, medications that have been tried. Very commonly that goes with asthma is also allergies and sinus disease. So I ask and talk a lot about sinus disease, other medications, food allergies, and then things like sleep apnea and acid reflux that if untreated can make asthma worse. So as I mentioned, making the diagnosis of asthma requires objective testing, and that testing is lung function testing or pulmonary function testing. So what we do is we bring you into our lab at Stanford. Actually, there's now spirometers that can be used at home, but usually you come into our office, we bring you into a room, we put a little clip on your nose, as you can see here, and then we give you this tube and we say, breathe normally. Then we say, take a deep breath. And then we say, blow, 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 blow. And we ask you to blow as hard as possible. Sometimes we put birthday candles on a screen and say, try to blow them out as hard as you can. All these things are trying to look for how much air you can get out and how much air you can get out in your first second. And then we look at that ratio of the amount of air you're able to get out in that first second versus the total amount of air you're able to get out in the total time you breathe out. And that helps us get a sense of if you have trouble getting air out, which we see in diseases of obstructive lung diseases like asthma and COPD. And then often we'll give you a medicine like albuterol or some kind of short-acting, what we call a bronchodilator to open up the airways and see if your lung function improved, which is more suggestive of asthma because, that key is that reversible component. And what are some things we see that mimic asthma and can be mistaken for asthma? Autoimmune diseases, vocal cord dysfunction. For some reason, when you speak, your vocal cords are supposed to go in and then air passes through them to produce sound. But for some people, for some reason, their signals get mixed and their vocal cords go in at inopportune times, and you can have difficulty getting air out, shortness of breath, wheezing, but it's coming from up here in the throat rather than down in the lungs. Tumors, tracheobronchomalacia is when the big airways get floppy. Deconditioning, cystic fibrosis, bronchiectasis, COPD. Often heart failure with fluid retention can lead to wheezing and shortness of breath that on the surface can seem like asthma. And something I see a lot are ALS, myasthenia gravis, or other neuromuscular diseases that can start with just some shortness of breath that can get mistaken for asthma. So once you've made the diagnosis of asthma, the next thing to do is really to evaluate the asthma phenotype, or that Th2 high allergic or non-Th2 high non-allergic phenotype that I mentioned before. And so often I will recommend patients to get, if they have symptoms suggestive of allergies and this type of phenotype, I will ask patients to get either skin or blood testing for allergies. So allergy testing can be done either through the skin or via a blood test. The blood test is pretty good and will measure your IgE or your reaction to multiple different things in the environment. I do have to say the skin is a little better at picking things up. It is possible that if something is negative on a blood test, it could still be positive on a skin test, but it tends to be much easier to do the blood testing. And we've kind of moved more towards that, especially during COVID. I also will order a complete blood count or a CBC with a differential, looking for these peripheral blood cells called eosinophils that are your allergic cells. As that's a good marker if they're higher than probably 150 to 300, that you have some kind of allergies or allergic type asthma. I also often in my office will check a pheno. That is an acronym for fractional excretion of nitric oxide. Basically, you blow into a tube and it takes a measurement of the eosinophilic or that allergic inflammation that's specifically in the lungs. And here I just have an example on the bottom of what allergy testing would look like when you are positive. Once the asthma diagnosis is made, other assessments I will make is I will look at inhaler technique. Up to 90% of people, it's thought, use their inhalers wrong. And in a couple slides, I'll get into why that is. You know, as there's so many different inhalers on the market now, you know, as inhalers become generic and are going off patent, the companies will tend to make some modifications to delivery mechanism, and then it gets to go back on patent. So there's just so many different delivery methods for inhalers now. Also, adherence. Many inhalers have to be taken twice a day. Many people find it very hard to remember to take their inhalers or their medications. Things I will make sure is that patients have a written asthma action plan, which we'll talk about at the end, that they know what to do in case their asthma symptoms worsen. I also assess their comorbidities. As I mentioned, things like uncontrolled acid reflux and sleep apnea can make asthma worse. So I always, you know, or uncontrolled sinus disease or allergies. So I always address those. And things you should consider are intermittent measurements of lung function. So this is a slide that kind of goes over just the very basics way to use your regular MDI or puffer inhaler. That's probably the classic type of inhaler. And I go through this with my patients. We also now in our Emeryville clinic offer video visit inhaler teaching video visits. I refer patients to their pharmacist or tell them to watch YouTube videos, all these things to make sure that they're comfortable using their inhalers because it's so important. But generally for a regular inhaler, what you want to do is take the cap off, shake the inhaler to prime it. You want to make sure you're standing up. You want to take a full breath out. Then you want to put the inhaler in your mouth or just right in front of it. And then very pushed. So basically, this is where it's important to coordinate the movement. You want to push down on your inhaler while taking in a deep, slow breath. And then very important, you want to try and hold your breath for 10 seconds before breathing out. And that's for the first puff. If your inhaler requires you to do a second puff, then you have to do steps 2, 3, and 4 all over again. You don't need to reprime, but, you know, breathing out, putting it in your mouth and doing the slow, deep breath in after you push and holding in for 10 seconds. And here's a slide, like I mentioned, just going over all the different types of inhalers that are available today that your physician may prescribe. So you have your MDI, as I mentioned, which is just your regular puffer, which can be used with or without a spacer, which is a little tube that I'll show you that helps the medication delivery. You have your discus, your HandiHaler, a twisthaler, a flexhaler, a neohaler, a Respimat that has a soft mist come out. And then some inhalers I prescribe are in an ellipta. So some of these are dry powder, some of these are mists or aerosolized particles. So it really depends, and you may find many patients have a preference one way or the other. I have many patients who don't like dry powders. Some people, if your lung function is really low, it can be hard to generate enough force to take in a dry powder. But some of the dry powders are nice because many of them can be given just once a day, which really makes it much easier to take. So it really depends, and it deserves it's going to be between you, your physician, and your insurance coverage. So like I mentioned, I try to give patients inhalers that can be used with spacers whenever possible because it really helps with medication delivery. No matter how good you are at using an inhaler, some particles are going to get deposited in the mouth. Spacers are just different types of tubes that can be put on the end of your inhaler that help coordinate the breath and inhaler movement and help those little particles get into your lungs. Particularly important for patients who have difficulty using their inhaler And very commonly, I'll really try to use these for patients who get like recurrent yeast infections in their mouth with using their inhalers to help them deliver, try and get as less depositing in their mouth as possible. Okay, so let us move on to the next step, which is assessing asthma severity and control. So asthma severity is really assessed retrospectively, and it's based on the amount of treatment required to control symptoms and exacerbations over the last 2 to 3 months. So mild asthma, although we don't like to use this term because it doesn't necessarily mean you're low risk, but mild asthma is the most common form of asthma, probably 50 to 75% of patients with asthma. And these are patients who are well controlled just using as needed treatment. These are patients who have good symptom control and they don't need to take an inhaler every day. Then moderate asthma means someone is well controlled, but they do need to take a regular controller therapy with an inhaled steroid every day. Severe asthma is the least common type of asthma, but the type of asthma I see the most that gets referred to a specialist. And this is asthma that's uncontrolled or remains symptomatic despite optimizing treatment with high dose regular daily steroid inhalers and oftentimes multiple other controller medications and inhalers. And then at every visit, I assess asthma control, how well we're doing with your current medication regimen to keep your asthma controlled. And this is really a two-part thing. It's basically how well are your symptoms controlled and how high risk are you for having an asthma exacerbation, because that's really what we're trying to avoid when we're treating patients with asthma. So again, in terms of symptoms, big questions I ask are frequency of nighttime symptoms, which is something I mentioned earlier on. This is something cough, chest tightness, wheezing, shortness of breath that wakes you up at night or earlier than usual in the morning is tends to be very common in uncontrolled asthma. And I don't like any nighttime awakenings, but definitely, more than 1 or 2 a week is very concerning to me. Also frequency of rescue inhaler use, I like people to be using their rescue inhaler no more than 1 to 2 times a week. Any more than that, and I start to get concerned that their asthma is not well controlled. And one of the tools I use frequently with my asthma patients is assessing the ACT score, which is a validated 5-question instrument with just 5 easy questions that lets me calculate a score to see how well controlled someone is. And I'll show you that on the next slide. Then part 2, again, is how high risk are you for having an asthma attack or an asthma exacerbation? So the biggest risk factor for an asthma attack is having had at least 1 attack in the past year. That is probably the biggest thing that increases your risk of having another one. Other things that increase your risk of having an asthma exacerbation are incorrect inhaler technique, which is again why it's so important to always be addressing that, low lung function, and smoking. There's many other things, but these are some of the big ones. So this is the asthma control test, or the ACT as we call it. I have this in all of my notes, and I ask this at all of my visits. Many pulmonologists or lung doctors will. Basically, it's 5 questions on a scale of 1 to 5. And if your score is 19 or less, your asthma may not be well controlled. A score of 20 or better indicates good asthma control. And basically what we ask are symptoms over the past 4 weeks. So the first question, in the past 4 weeks, how much of the time has asthma kept you from getting as much done at work, school, or home as you would like? During the past 4 weeks, how often have you had shortness of breath? Over the past 4 weeks, how often have you had asthma symptoms that wake you up at night or earlier than usual in the morning? During the past 4 weeks, how often have you had to use your rescue inhaler or your nebulizer? And then the last one is important too. How would you rate your asthma control? Do you think you're controlled, or do you think you're not controlled at all? And that's, the important last question we ask there. Okay, so this takes us into the basics of asthma management. So we already talked about this, but step one, like you even knowing where to start and where to go with therapy, is assessing severity and control. So that's definitely where you have to start. Then once you kind of have figured out somebody's, severity and how well controlled they are, you can start to make some treatment decisions. So for mild asthma, generally I will start, with an as needed inhaler with an inhaled steroid and a long acting bronchodilator. Alternatively, if this is not covered by insurance or if this is not okay with the patient, I will tend to recommend just using 1 to 2 puffs of an inhaled steroid inhaler whenever the patient has to use their rescue short-acting beta agonist or their rescue inhaler. For moderate asthma, I will start a controller medicine with a low-dose inhaled steroid and a long-acting bronchodilator. And then for severe asthma, patients often need high-dose inhaled steroids on a daily basis and may need even like 2 or more different inhaled bronchodilators and even injectable medications, which are biologic medications. 6 of them are now approved that target those different chemicals in the allergic and non-allergic asthma pathways. So here is a graphic from GINA, which is kind of the global body that makes recommendations for asthma diagnosis and management, by looking at all the evidence that comes out and then making recommendations. And as of 2022, this is the recommendations for treating asthma for anyone 12 years of age and older. And basically this track 1, or the preferred treatment pathway, if insurance would cover it, is to use, again, as I mentioned, a low dose inhaled steroid with formoterol, which is a long-acting bronchodilator, like a long-acting albuterol, as needed. And then as your asthma gets worse, then you have it be a low-dose maintenance inhaler, like a daily controller with ICS formoterol. Then as your asthma gets worse, you increase the steroid dose until, again, step 5, that severe asthma, where you're adding on other different types of therapies. So I mentioned this because this is super different than many people. As I mentioned, I see patients all the time who had asthma in childhood, and this is like totally different than how their asthma has ever been treated before. And this is because, for 50 years, asthma has been treated first line with a short-acting bronchodilator, mostly albuterol. Like most people with mild asthma have just been treated with albuterol. And so this is very different than this recommendation to give everybody low-dose inhaled steroids plus formoterol as needed, or a low-dose steroid plus albuterol as needed, rather than just albuterol. And this is because for 50 years, we really thought that asthma was just a disease of bronchoconstriction, that in response, like I mentioned, to triggers like pollen, viruses, or cold air, that the airways clamped down, you would give the albuterol or the short-acting bronchodilator, the airways would open up and that would fix the problem. And, patients like this, it's good. Patients like that they can just carry their albuterol in their pocket. If they have symptoms, they take it, they feel better and they tend to rely on that. And, it's low cost, it relieves symptoms. So this all seems pretty good. And patients commonly think, if I have my albuterol, I'm okay. It gives me control over my asthma. But the problem is that we now understand that asthma is really, as I mentioned, going back to that first slide, is a disease of chronic airway inflammation. And just opening up that airway with the short-acting bronchodilator, the albuterol, is not addressing the inflammation that's causing the problem in the first place. So in 2019, there was really a fundamental change in our approach to the management of asthma. Because of this better understanding and all the evidence that we've accumulated in the research over time. And really, as of 2019, it's no longer recommended that any adults or adolescents over 12 with asthma use short-acting bronchodilators like albuterol alone. really now we recommend that all patients with mild asthma should get symptom-driven treatment with inhalers that contain steroids and bronchodilators, and that patients with moderate to severe asthma should really take daily steroid-containing inhalers in addition to long-acting bronchodilators. And really, again, this change was made for several reasons. Because we better understand that it's really a disease of inflammation, but also because patients with apparently mild asthma are still at risk of exacerbations and serious adverse events like asthma attacks or even fatal asthma. And the problem is, the triggers of these exacerbations are so variable. All you need is one bad wildfire and really bad air quality day, and it can put somebody with, mild asthma into exacerbation. So they're going to be in a much better way if that inflammation in the airways is controlled and less likely to have something really bad happen in that kind of situation. Also, you never know when you're going to get a virus, when the pollen counts are going to be high, all sorts of things. So really at the end of the day, this is a population-based risk reduction strategy, kind of like blood pressure lowering pills or cholesterol lowering medications. You take your statin, your cholesterol lowering medication, your blood pressure medication. It doesn't necessarily make you feel better, but over time, it's going to reduce your risk of having complications if you have high blood pressure, high cholesterol. And that's kind of the same thing with this idea of using the steroid-based inhalers for everyone with asthma. Each patient may not necessarily feel better using, a steroid inhaler with a bronchodilator than they would if they just used albuterol. But again, it's a bigger picture intervention to decrease inflammation and prevent asthma attacks and serious adverse events for everyone. So now that takes, we talked a little bit about the importance of everybody kind of having a steroid-containing medication. So let's get a little bit more into the different medications we use for asthma. So in general, there's two types of medications in asthma: controller medications and rescue inhalers. So controller medications are the ones that you take daily or twice daily, in some cases on a regular basis. These are your steroid inhalers that decrease airway inflammation, open up the airways, improve symptoms and lung function. There's so many different types, but I tried to just write here the names of as many I could think of off the top of my head: Flovent, Symbicort, Advair, Wixela, Dulera, Brio, Alvesco, Qvar, Brio, Trelegy, and Breztri are just some of the ones we use as controller medications. And then your rescue inhaler is what you're going to use for acute relief of symptoms. These usually contain a short-acting bronchodilator unless you're doing smart therapy. So now for many patients, if you have that recommended medication, that inhaled steroid with formoterol, which just to use it in layman's terms, that's Symbicort. So Symbicort is really the preferred medication for everyone because it contains a steroid and formoterol, which I mentioned earlier. Formoterol is a long-acting bronchodilator, so it's a long-acting medication that opens up your airways, but it's pretty special in the way it works because it starts working fast, so it can give you acute relief, but it lasts for a long time. So it can also act as a controller medication. So for my patients that take Symbicort, they can use that as SMART therapy. SMART is an acronym for single, maintenance, and reliever therapy, which means that your controller medication, your Symbicort that you take every day, you can also use as your rescue inhaler, up to 10 to 12 puffs per day. Although there's a bigger problem if you're taking 10 to 12 puffs of your inhaler a day. In addition, I have many patients who do use their Symbicort inhaler every day as a controller therapy during the winter, during the respiratory virus season, or during the spring when the pollen is bad, if they're very allergic to pollen. and then they just use it the rest of the year as an as needed basis, kind of like a rescue inhaler. So there's different ways that you can use these inhalers. And now with these new management guidelines, the lines get a little bit blurred between rescue and controller. And then something I get asked about a lot is, what about nebulizers? Do I need a nebulizer? So I think nebulizers are great. Basically, nebulizers create a mist of aerosolized particles with the medication, and they can make smaller particles that more readily deposit in the lower airways than the inhalers. Really important for patients when they're in an exacerbation and they're having trouble breathing, or for the very young or the very old, or people with developmental delays who have trouble using or coordinating the use of their inhaler. A nebulizer, you just put it on your face, like in this picture, and it creates this mist, and you don't have to coordinate the actions of using the inhaler and taking a deep breath in. But at the end of the day, there is no evidence it's more effective than an inhaler used with a spacer. But for my patients who do end up going to the ED or urgent care to get nebulizer treatments, more than once or a year or so for asthma attacks, I will prescribe it for them. So they have it, more so that they can avoid, going to the urgent care or ED or getting hospitalized. Okay. We are almost done. In the final part of this talk, I just want to talk a little bit about common asthma attack triggers and how to manage them. So asthma attack triggers, as I mentioned, are very variable, including pollution, smoke, pets, and different allergens. Some of the most common ones I will address today. So many people are allergic to dust. If this is you, the best thing to do is to make sure that you have hypoallergenic dust covers on all your mattresses, pillows, your box spring. Important to wash your bedding weekly in warm or hot water, dry it on high heat. Important for many of the things I'll talk about, including mold and pests, is it's really important to keep indoor humidity low. Patients ask me frequently about humidifiers. I am not a fan, and even with my own kids, I was really scared to use them, even when they had colds. I'm not saying I'm the kind of person who will never say never to anything, but I'm not a fan of humidifiers for the reason of promoting dust, mold, and other things. It is important for a lot of my asthmatics. I will write them letters. It's important to use air conditioning to help. It's one of the ways to kind of clean and cycle air. And also, if you really have problems with dust, it's important to try and remove carpets from the bedroom. Rugs tend to be better as they can be removed, shaken out, cleaned easier. What about pets? So I will put a little thing here is, if you have allergies and asthma, please, please, please really think hard before you get a pet. Even hypoallergenic pets are not truly hypoallergenic. And once people have pets and they're giving them problems, obviously, they're like people's children. I know I grew up with pets too. I can understand, but obviously nobody wants to get rid of their pets once they have them if they're creating problems. So, think hard if you have asthma and allergies about getting pets. And if you do have them and they do create problems, at the very least, keep them out of the bedroom. That's where you spend the most time. Keep them out of the bedroom. Keep them in a room with a HEPA filter, with an air purifier with a HEPA filter, and always also use a HEPA filter in your bedroom. Can try covering the air ducts that lead to the bedroom, and just vacuum frequently. And again, people ask me a lot about air purifiers and HEPA filters. For anyone with asthma or allergies, especially during, when we had those years of bad wildfires, I am a big fan of air purifiers with HEPA filters. But no, I don't have any preferences on brands or types. I think whatever is affordable for you. And just make sure that you look at the specifics and that it cleans the amount of air you need it to clean for what you're using, because they all have different, volumes of air that they clean. And what about air pollution and wildfire smoke? So I think last year or two, it hasn't been as bad, but here in California, this is a big problem. Are the wildfires tend to be in the fall. They can be really, really bothersome for patients with asthma and airways diseases and allergies. I mean, they can be bothersome for everyone, but especially those patients. We know there's increased risks of asthma attacks, even heart attacks when the air quality is poor during the wildfires. I talk to all my patients about monitoring air quality, avoiding going outside when it's, yellow, definitely orange, avoiding exercising outdoors, running the air conditioning, running air purifiers. And if you have to go outdoors, recommend using a KN95 or an N95 that we all know about now in the era of COVID. Because the regular surgical mask or a scarf over your mouth is not going to filter the small particulate matter that's generated in the fires and that gets into the airways. And then I don't think I even have to talk much about this slide. Don't smoke. If you have asthma, smoking is very irritating. I showed that that's one of the biggest risk factor for having asthma exacerbations, having poor lung function. Anything inhaled, cannabis is legal now in California. I often will not say to my patients, don't use cannabis, but I'll say, if you do use it, edibles, nothing inhaled. It's just not good for people who have asthma. It tends to be very irritating. And then mold, something I deal with a lot as, in my practice is allergic bronchopulmonary aspergillosis, which tends to affect people with asthma specifically. It's a allergy in the lungs to mold that can create really uncontrolled asthma and has to be treated a little bit differently than regular asthma. Unfortunately, mold is an airborne species that lives in the soil and is found in water damaged structures and tends just to be really ubiquitous in the environment. The spores are really tiny and get inhaled easily and just deposit in the lower airways. And in most people, they're just cleared. The lungs are not sterile. All day, we're inhaling everything that's in the air, every virus particle, pollen particle, and it gets in your lungs. It gets trapped in the little cilia or the hair-like projections that line the airways, and it kind of gets pushed up, expelled in mucus, and you swallow it and, nothing happens. It's fine. But for some reason, people with asthma tend to have impaired clearance and are at risk for these spores, not getting cleared out of the lungs and creating problems. Again, not trying to create, fear, but it's just something to watch out for. So I do recommend mitigating mold exposure if possible. Again, keep humidity as low as possible. Mold loves humidity, anything above 50%. I think around 55% is its ideal growth environment. So keeping humidity low, quickly addressing any plumbing leaks or source of dampness or standing water. I don't think you have to go crazy, but, making sure there's no areas of visible water damage in the home. I rarely will recommend a need for a professional mold assessment. And really, if there's no visual mold, I don't think there's usually not a real reason to do air quality sampling or things, because there's no evidence on how to deal with that. And remediation is really only needed for severe infestations, high particulate burden, or known mold-associated lung disease. So I think, finishing up, it's important for all patients to have an asthma action plan for what to do if asthma worsens, especially in response to some of these triggers we talked about. This should be a plan for asthma management developed with your physician. It should be individualized. It should be written. That is something that has actually been shown to be improve outcomes over just verbal asthma action plans. It can include peak flow or other lung function monitoring. It can just be symptom-based. And it should talk about how to monitor your symptoms, what you should do with your medications, and when to seek medical attention. And we're running out of time, so I'm not going to talk much about this, but we often will use things called peak flow meters. that assesses the highest airflow rate to keep an eye on lung function and combine it with symptoms to know when you need to seek medical attention or add medications to your regimen. Here is an example of a written asthma action plan, like what to do when you're in the green zone and you have no symptoms, when you're in the yellow zone and you may have starting to have some symptoms of your asthma acting up, and then what is your emergency plan if you're in that red zone. Okay, now I promise last couple slides. Other things that I'm very big on just for general lung health and that are very important, especially for asthmatics, are keeping up to date with all your vaccines. Lungs are the first line of entry for many viruses and bacteria, flu, COVID, pneumonia, all of those things. And recurrent infections can impair lung function. People with asthma tend to have prolonged recovery after infections. I'm not going to talk about specific vaccines, to always talk with your doctor about that. Although I do want to note that all adults with asthma should have pneumonia vaccine at some point before 65. Most other people can wait till 65, but if you have asthma, you should definitely get at least one before 65. Other things I will talk about with everyone is weight. I know that losing weight is so hard, and everything in our society is designed for us to hold on to weight. But especially in asthma, being overweight can really lead to problems. We know it worsens asthma. It makes your lungs more hyper-responsive, and often losing weight can really help improve asthma control. I have many patients who've lost weight and their asthma, they go from being on tons of medications to none. So it's always something I talk about. And if people are candidates, I'm very commonly will refer them to get medical weight loss treatment, just because I know how much can help their asthma. So that leads us to this last slide, which is exercise, exercise, exercise. Just like your skeletal muscles, your respiratory and cardiac muscles need to be exercised. We know that exercise helps your lung function, helps with asthma. Even people with like the worst asthma who feel short of breath when they exert themselves, when we do studies, really usually what's limiting people is deconditioning. So I always recommend people to try and exercise as much as they can. Because not only is it going to feel better, make you feel better, but it can really help manage asthma symptoms. So with that, I know I talked a little bit too long, so I will open it up to finish with some questions. So let's see. Is it common for people who had childhood asthma to have both Th1 and Th2 type asthma as adults? So, this is a good question, and I don't fully know the answer to this, but it definitely is more common for people with childhood asthma to have allergic asthma. Much more common in childhood is allergic asthma. Oftentimes late onset or new onset asthma in adults tends to be non-Th2 high or a non-allergic asthma, but not always. It can definitely be allergic type 2 high asthma. Type 2 high or allergic asthma tends to have more treatment options these days. So if there is that element, I will usually treat it like that. Okay. Next question. Can asthma go away in adults? Yes. So this is super common. It is very common for childhood asthma for some reason to, I don't know if go away is the right word, but kind of go into remission. Many people have asthma in childhood, and then in college or adulthood, we'll find that they no longer have symptomatic asthma. Unfortunately, although for many people it stays this way, it can come back. And I do often see that it can come back later in life in response to different things, such as a prolonged respiratory illness, or even, just the changes in hormones for women after menopause or as we age, or from other things. Okay. How about, since the deposition of the MDIs is certainly increased with spacers, why is the technique that is, though not including a spacer or chamber, the default for every patient? This is a really good question, and I don't 100% know the answer. As a lung doctor, anyone whose inhaler can be used with a spacer, I try to get them a spacer. But I think, because inhalers don't come with spacers and it has to be ordered separately, I think that we automatically just go to the default of teaching people how to use their inhalers without a spacer. Again, this is a really good question, and I like this. I mean, I wish every inhaler could be used with a spacer, and that every patient could use a spacer. So I think you have a good idea here, and if this is something we could work on together in the future to design something to get it to work this way. Okay, couple more. So what are the symptoms of oral thrush from inhaler use, and how is it treated? Okay, so good question. So this is kind of what I mentioned when I talked about how important it is to correctly use your inhaler. So unfortunately, now we're recommending everybody take an inhaler with an oral steroid in it, an inhaled steroid in it. And no matter how good you are, some is going to get in your mouth. Obviously, if you use your inhaler wrong, there's more chance of more medication depositing in your mouth. And this can lead to a yeast infection or something we call thrush in the mouth. Generally, this can be easily treated. The most common thing I will use is something called nystatin, which is an antifungal medication that you swish and swallow or swish and spit a few times a day for 7 to 10 days, and this will often treat it. For patients who have recurrent thrush, let me take a step back. Whenever I'm telling somebody about using their inhaler, I always tell them to keep it next to their toothbrush and make sure they gargle, brush their teeth, or rinse their mouth really well after they use their medication to prevent this in the first place. If somebody's having recurrent thrush, I'll make sure we go over their inhaler technique. If possible, I'll reduce the steroid dose in the inhaler. If I can, I'll try to switch them to one with a spacer. And in really bad cases of thrush, sometimes people need to take oral antifungals like fluconazole, but I try to avoid that if possible because that has a lot of medication interactions. Oh, okay. I like this one. What are the recommendations on doing allergy shots if you have pet allergies and you want to get a pet someday? If you're really, really symptomatic and you have really bad allergies to a pet and you really want to get one, I'm all for allergy shots. The thing is, it's a big time commitment. I'm not an allergist, so I won't get into the specifics, but you do need to go very frequently and build up to a maintenance phase. And then you kind of have to stay on the allergy shots if you want to maintain your sensitization often. Sometimes you do it and it stays, but not always. But the one thing is your asthma has to be well controlled to get allergy shots as well. But definitely, I think if you're interested, it is worth getting a referral to an allergist to discuss. Okay. And maybe one more. When is it appropriate for a primary care doctor to refer a patient to a specialist like a pulmonologist? So as a pulmonologist, I think I'm a little biased on this, but I think that most primary care doctors can manage pretty, mild asthma. I think at least if they feel comfortable, if a patient has clear asthma, the right symptoms, the right pulmonary function testing, and they're responding appropriately to first-line therapy with a medication like a Symbicort or an low-dose inhaled steroid and a rescue inhaler, I think that's fine. I think when there's a question about the diagnosis or a patient isn't responding appropriately to treatment, or they have more moderate to severe asthma, especially because we have so many new therapies to offer, in terms of injectables and things, I think it would be appropriate for a referral to a pulmonologist. So I think with that, I will finish up.
Thank you, Dr. Eggert, for sharing this great information. And thank you to our audience for joining us and for the great questions. If you'd like additional information or resources, please contact the Stanford Health Library. We hope you'll join us for our next lecture.